Join us this evening as we host one of our viewers' favorite shows, Ask Anything. Tonight's show focuses on all medical topics affecting those in our viewing audience. Ask Anything tonight on Call with the Prairie Doc.
Welcome to On Call with the Prairie Doc, health information based on science, built on trust. I'm your Prairie Doc host, Dr. Kelly Evans-Hullinger, and tonight we will be answering all of your questions about any topic. Tonight is one of our viewers' favorite shows, Ask Anything, where viewers can call in, email, or message us any medical question they have. Having access to trusted health information can play a pivotal role in improving community well-being by promoting knowledge and healthy practices across all age groups, addressing a wide range of health issues from chronic diseases to mental health, and influencing policy and economic outcomes. Prairie Doc strives to provide this type of resource each week. Thank you for joining our discussion. This evening, we are joined in the studio by Dr. Carolyn Gilbertson from Sanford Family Medicine and Dr. Arleigh Trainor from Sanford Emergency Department, both in Sioux Falls. Welcome to you both, and thank you for joining me here tonight. Carolyn, tell us a little bit about yourself. Where are you from? What do you do in family medicine?
So I'm originally from Brookings. I went to college at the University of Minnesota Morris, and then from there went to University of South Dakota for medical school. Went to residency in Sioux Falls at Center for Family Medicine, and have been practicing in Sioux Falls ever since. Now I'm doing a bit of a blended practice where I'm at the medical school part of the time, and then seeing patients part of the time as well.
Yeah.
So.
And you also do obstetrics,
Yes.
which isn't universal in family medicine, but
Right.
that's a big part of your practice.
Yep.
Is that correct?
It's a big part of my practice. It's one of my favorite things, getting to deliver babies and help families through that whole process.
Yeah.
So.
And our viewers might remember a show that you have a connection to on South Dakota Public Broadcasting,
Yeah,
right? We were just
yep.
talking about this yesterday. Your
Yep.
dad, what was his role? And
Yeah,
what
so
was the
my
show?
dad was Marty Draper, and he was the he was the host of Garden Line.
Yes, Garden Line. I remember that airing when we were kids.
Yep. My sister and I would run questions from the phone room into the studio.
Yeah.
When we were kids.
Yeah, so you've been in a studio. It was on this campus too, wasn't it?
It was in Pugsley.
Awesome. Yeah. Arleigh, thank you for joining us. We don't get to have emergency docs on this show very often, so we're happy to have you here.
Happy and privileged to be here.
Tell
Well,
us,
thank you.
tell us about your path and what life is like as an emergency medicine doc.
Sure. I had a bit of a circuitous path. I wasn't always knowing I wanted to be a doctor, but finally got there, and I went to the University of North Dakota for undergrad, and then took a bit of a break and did medical research for a while and explored whether or not I wanted to do a PhD or an MD. Got married in that time, and then both my husband and I, was a Minnesota boy, applied at the same time, and it just worked out that North Dakota was the spot that we both liked the best for both of our respective degrees. So I ended up going to med school there, and then I did residency in the Twin Cities. And actually, my husband got a job offer at Augustana College in Sioux Falls, and that's how I ended up in Sioux Falls, South Dakota.
Yeah, so you've been there for a while.
Yes, yes.
What, I mean, most of our viewers, luckily, don't interact with an emergency department all that often. Like, what do you find are either misconceptions, or what would you like every person to know about an emergency department?
Yeah. Well, what I think is the joy of doing my job is that we are always there for people, and that's what I always want people to know. There's never really a wrong answer. I tell my students and residents this. It really is the perception of what is an emergency for you. Sometimes we may not be able to give the answer or the diagnosis, but people come to us because they're worried and they're scared, and that's what we're there to help with, and then direct you to either get the care that you need immediately at that moment in such things as a heart attack, or if you break your arm, or if you have a pneumonia in your parent that's so bad that maybe they have to be admitted to the hospital. But sometimes we also have to then refer you on maybe with some medications or things like that. So that's the one thing I really like about my job, is that we're always open and we are always there to care. I never have to worry about, oh, but we're going to be closed, so maybe we can't fit you in.
Right.
The next person will always be there for it. And we also always know that we're probably seeing you on the worst day of your life. And we understand that, and we try as much as we can to be as sensitive as possible to that, because we are acutely aware of the privilege of taking care of you on the worst day of your life, and also the challenges that that is. So it's a very sacred and humbling time to be within that. I think we saw that definitely with the pandemic, where at that point, one of the few things that were open was the emergency department. And the conversation now has started a little bit more nationally. There's some TV shows that are super popular right now, targeting the experience of being in emergency medicine. I know, and this generation's is very popular again, because some of the new TV shows out there, which I think is good, because maybe that'll generate some more interest for getting people into emergency medicine as well, because we always need more ER doctors.
Yeah, great. Well, before we start our conversation, we invite you, our audience, to submit your questions for tonight's discussion about any medical topic. Viewers can contact us 3 ways. Call 1-888-376-6225, send an email to ask@prairiedoc.org, or ask on our Prairie Doc Facebook page. We will work to answer as many of your questions as possible given the time available. Sometimes we receive more questions than we can cover, and we apologize if we do not get to your question. Your question will remain anonymous and no information is saved. Viewers can leave their name, email, or phone number to be entered into a drawing for our Prairie Doc publication, Perspectives from the Prairie, but it is not required to submit a question. The winner will be drawn and announced at the end of this program. Let's just get to some viewer questions, see what we can get answered. Let's see. We have a question from Facebook from a woman in her 50s. She says, I've been getting frequent urinary tract infections in past months. This started a few months ago and was never a problem before then. What can I do to prevent this from happening more? Carolyn, why don't you start? This is a super common problem that we see, right? Yeah.
Right. So, and particularly in that decade of life, we can see that urinary tract infections or genital urinary problems in general can be more of an issue as we're reaching menopause. So making sure that you're drinking enough water is one thing. Another thing would be to have a conversation with your doctor and have an exam and see if maybe there is something structurally that's changed. In menopause, the tissues around that area can just become thinner and more prone to infection, and so sometimes there can be a role for like a topical estrogen therapy, or there's also a role for sometimes like a vitamin C supplement, or sometimes we'll do cranberry supplements as well. So lots of options, but if it's a change that's happened recently, I think it's really important to get it investigated and figure out if there's something that we can be doing differently.
Yeah, and it's probably not your fault. I get the question,
Right.
Like, what am I doing wrong? And it probably has nothing to do with anything that you're doing.
You're not washing wrong, or you're not dirty. It just is a dumb thing that happens.
I also think that with these, it's super important, if you can, because we see a lot of people that come in because this is something acute, so it's something that comes out of the blue and it's horrible pain or there's blood coming, that oftentimes you'll seek care in an acute care because maybe you can't get into your primary. It's super important then, if you're getting these recurrently, to follow up with your primary, because sometimes it may not even be infection, even though the first screening process may show that it's infection, and that's maybe what you've been told initially, but it's so important to follow up with your doctor then if you're seeing a new trend in having these issues to ask about the functional things, because you may have more of an irritation than even infection, and then you may be taking all these antibiotics unnecessarily. And it's expensive, it's time consuming, it's days off, it's time to get into the clinic. And a lot of people just kind of accept, oh, this is my life now, having these recurrent infections, and they hearken it back to when they were in their 20s and had these issues, but it's very different at the different age.
Yeah, that's a great tip, because your primary doctor may not even know that this has been happening. And I've had this conversation multiple times. Actually, I don't think these last few visits that you've had were infections, even though that's what they thought at the time and you got antibiotics. I think we probably need to do something differently about this. So great tip. Let's see, we have another question from email. Arleigh, this person has had a bad cold for the last week. They must have done a home test, which was negative for COVID. Wondering at what point do I need to go in? This is like, triage all the time. What are the things that, I guess, both triage about needing to go in at all, because, most colds, we don't do a lot more for that. And do you have good advice for people triaging, like, well, should I wait till tomorrow to go to the clinic versus going into the emergency room? What sort of symptoms really should prompt them to come to the emergency room?
So this is always challenging because typically I think this is a conversation you have with yourself at night. It's the 2 a.m. when you wake up and you're like, I'm feeling really bad. And then you start thinking about it more and more, and then you get more and more worried, and then it prompts you to say, should I go into the emergency department? And what is that trigger? Because it's very frustrating when you come in and you wait to be seen, and then if they don't give you an antibiotic, or you don't have those things, or they suggest supportive care, and then people are sometimes, unfortunately, they even will feel embarrassed, which you don't need to. You're not the doctor. It's not your job to figure this out. There are some red flags that just are always there. And if you have these, always come and see us. Don't call the nurse line. Don't worry about that stuff. Just come and see the emergency department. And sometimes you should even call an ambulance for it. If you are short of breath, where you are having trouble speaking, if you are having trouble walking more than a few steps, or if you notice that there is blueness around your hands or your mouth, whether you or your loved ones, you need to come and be seen immediately. That is just one of those things that is very important. The other thing is, if you've noticed that you've had a fever for more than 5 days, because that's kind of a tipping point that we talk about for a viral illness. If you have had persistent fever greater than 100.4, that's another thing, because then you may have moved from a viral illness to where it's seeded into your lungs or into your sinuses or somewhere else, and then it becomes bacterial, and you may need more care, as opposed to, stay home, chicken noodle soup, take your over-the-counter stuff, Tylenol, Motrin, but that's a tipping point as well. Or if at any time you're not able to think clearly because you're so sick, or you're so weak that you're having trouble getting up from your seat, or you're having trouble getting out of bed, those are the big triggers that is not okay. You should come and be seen by us, because don't wait till morning. It is okay to be seen now, because you might not be even aware enough by morning, especially in some of our elderly patients, to make it there. And then sometimes we have these unfortunate cases where somebody finds them and then they're much sicker than they were the night before. So if you have any of those, very severe shortness of breath, changes in your ability to think because you're so sick, high fevers that are more than 5 days, or inability to get up or get around that is not normal for you, that extreme weakness, come immediately to see us. We are happy to see you. We'll take care of you. Right? We will take care of you. And don't worry, we're awake and open all the time. So if it's 2 a.m., please come in at 2 a.m. It's actually less busy. Good answer. I think, in the less ill person, just persistent cold symptoms, what do you tell your patients? Like, when do I need to see you when you've been nursing a cold at home?
If it's been a week and the symptoms
better.
are not getting better, or if they start to get worse, they got better a little bit and now they're getting worse again, that's time to come in and see us.
Good. Okay. Another Facebook question. This is another woman in her 50s. She says, I had a spot on my nipple that itched and peeled, but then after a few days just looks like a red spot. Is it something I should be concerned about? How would you advise your patient, Carolyn?
You know, if it's never happened before and it got better in a couple of days, I think I would just keep an eye on it. But if it comes back, especially if it's in the same spot, it needs to be looked at.
Yeah, if it's something that's recurring or not healing. Okay, good advice. Let's see, we had an email question. My husband was diagnosed with hydrocephalus and is having a shunt put in next week. What is the recovery like for this, and are there restrictions now that he will be getting a shunt? We have a large acreage, requires a lot of mowing, so probably a pretty active 72-year-old. I mean, none of us are neurosurgeons per se, but Arleigh, do you have any advice for this person?
So I think the big thing that I see with a lot of these, so anytime you are having a different or larger surgery or intervention that is being done by a specialist, you need to have some very frank conversations with that specialist, both before and then after. And this can even be with the nurse in the office, because you will think of questions as soon as they walk out of the room. Your life may not change at all.
Right.
And the purpose of getting some of these things done is to keep you with the best quality of life that you can possibly have. But this always depends. Remember, none of us are exactly the same. Nobody's case is exactly the same. So these are great questions, but they are questions. I advise people, write it down in your iPhone or on a piece of paper.
And bring somebody else with you to your appointment to listen to the answers and help you remember.
And 2 sets of ears. And this is very specific, like, when can I mow the lawn? That's a great question for the surgeon. Yeah. Okay. Good.
And they're used to those questions. So don't ever feel like any of those are silly. They have had all the questions and more. So ask all of the questions, because there's nothing that we feel worse about as physicians to find out, oh, you didn't ask that? You were worried about it? I wish you had asked me, because we could have cleared this up for you.
That's easy. We could have answered,
right. Good. We had a Facebook question. My OB, after a few years of bad perimenopausal symptoms, prescribed hormone replacement therapy. She recommended a follow-up and blood testing after 2 months on it. What are they looking for? Carolyn? I don't know about the blood testing, I guess. Really, we're usually treating about symptoms, really entirely symptoms.
Generally, our treatment is guided towards symptoms. Maybe if they had some abnormal labs before starting treatment, that's something they would be following up on. But generally in my practice, I'm following symptoms, and usually there's a reason that we started these medications in the first place, whether it's hot flashes or vaginal dryness, recurrent UTIs.
And we want to make sure that the treatment is working, right? Okay, good. Let's see, an email question. My child has some sensitivity to milk, but not cheese. Is it possible to only react to some milk products and not others? I guess I'll ask you, Carolyn, since you do primary care for young kids.
So it depends. Like if it's a lactose issue, that'll be present in milk, but less in cheeses. Particularly hard cheeses are going to have lower lactose. So that could be it. And there's also varying degrees of sensitivities to milk proteins, and so sometimes we can tolerate a little bit that's baked into a muffin or a pancake, but not be able to drink a glass of milk. So, and that may be something that child will outgrow as they get bigger, but
so yes,
unfortunately,
it's
time will tell.
Okay, we'll do one more question before I roll in. We have an email question. My teenager has large mood swings during her period each month. Should we talk with her PCP about something like an antidepressant or something else to help with these big mood swings? Carolyn, this one's yours again.
So it's so hard to be a teenager. There's a lot of changes that are happening socially, emotionally, hormonally, and one of the best ways to start dealing with these things is by talking with a counselor or talking with a trusted adult. And it's about learning the coping skills to help get through these big changes in life. This is, generally speaking, adolescence is the first time that we have to deal with big emotions and big changes and potentially like choices that can have big consequences. So learning at a younger age how to cope with some of these things, because they're not going to stop coming later on in life. So, you know, in some cases a medication might be needed, but generally what we recommend is starting to visit with a counselor first and start to work through and find where are the specific issues.
But I think your PCP would like to know.
Absolutely.
They would like to know and monitor
please
this,
come
but
talk to us.
please let them know that, even if they do nothing about it. We actually like to know that type of information. We teach our med students to ask about things like that, so please feel free to tell us those things, because we actually do want to know.
Let your PCP help you find the therapist that's going to be a good fit for
They
you.
probably have good link to those resources in the community as well.
Exactly.
Yeah. The path to becoming a doctor is not the same for everyone. Dr. Tim Ridgway, Dean of the University of South Dakota Sanford School of Medicine and Vice President of Health Affairs, joined Prairie Doc to discuss what medical education looks like for students in our state.
Medical education is complicated in many ways because you not only need to learn the materials such as pathology, pharmacology, microbiology, and all those things, but you have to learn how to interact with patients, how to address patients' needs and treat them. So the medical education system is a little bit complicated.
Ridgway says the Sanford School of Medicine has 3 pillars as part of its curriculum: basic science, clinical skills, and career pathways.
Now traditionally, that was all classroom, but medical education has evolved. From day one at our medical school, we bring the patient to them. We try to use different clinical experiences to basically reinforce the concepts they're learning in the classroom.
Students can choose electives to support their education and help define their career.
The big thing with Pillar 3 is they prepare for something we call a residency program. When you get an MD after 4 years from any medical school in the country, you cannot practice medicine yet. You're still not ready. You have to do something we call a residency program. And that can be 3 to 5 years. So our students in Pillar 3 start going out on interviews. Some of them will do rotations in offices in different states because they want to be seen by these programs to see if, hey, maybe I can cut the mustard and I will rank them highly to do something we call a match.
The school's mission is to serve South Dakota, hoping that students will continue to practice medicine in the state.
So our mission is first to provide every South Dakota resident or anyone with a strong tie to South Dakota to get a high quality medical education. But the second, and I think this is important, is to provide a high quality curriculum to encourage our students to come back to South Dakota and practice primarily in underserved areas.
Thanks to Dr. Ridgway for doing that roll-in for us. We all love working with medical students. We think they're awesome. If you all see them in your clinics or asked to have a medical student see you, we hope you all say yes, because they're wonderful. We're going to just keep rolling with questions because we've got a bunch of them, all right? So next one from Facebook. I'm on blood pressure medicine and I work in a field that requires me to stand a lot. I wear compression socks and my blood pressure measures fine, but I still get swollen ankles. What could be causing this? Man in his 40s, sounds like they've seen their doctor, they've had a stress test that was normal. Swelling in the ankles. Arleigh, what would you advise this person?
We actually get this a ton.
Sure.
That people come in and they, again, start to worry about it. This is a very classic 2 a.m. Visit that somebody will get very worried about it or they're discussing it with a loved one. So there's a few different things that cause swelling of the ankles that we talk about, and some of them are very normal and not an emergency and not even really scary in terms of healthcare. But there are a few things that can cause it, and those are the things you need to be checked out if you notice it. So one of the things is if your heart isn't working correctly and it's not pumping the blood efficiently, it's something that we call heart failure. And a certain type of heart failure can cause swelling of the ankles, and you can get something called edema. And you may notice your doctor kind of poking your leg and seeing if the fingerprint stays. And that's one of the things we look for is we do some blood tests. Sometimes we'll do an x-ray, and sometimes we'll even do other tests like an ultrasound of your heart to check if that's the case, because then there's specific medication for it. The other thing is if your kidneys aren't working right, you can get this. So we'll also do a blood and a urine test, sometimes some types of pictures of the kidneys to see if those are working correctly, because that can cause it. Also, another thing can be if your liver isn't working right, and there's definite different precursors or reasons why that may or may not be occurring. We want to check out the reasons for that, check the status of your liver, see if there's any interventions that need to be done. There's a few things that can be emergent. This is usually more in just one leg. You may hear people that oftentimes when they come and see me, what they're most worried about is blood clot.
Sure.
It can happen in two legs, but it's mostly one leg. There's usually some pain associated with it and the swelling. There's usually an event that started it, whether you've just had surgery, you've been in the hospital and laying down not moving for a long time, you've been on a long trip where you haven't gotten out of the car, out of the airplane for a extreme number of hours, not 2 hours, but an extreme number of hours, or you're on medications that increase blood clots. But by far and away the most common thing I see, honestly, is that's just you as you're getting older. I hate to say it, but you can try and limit some salt, you can wear compression hose, but we see this more and more. The valves in your legs get old like the rest of you do. It's part of aging. Everything starts to age, and we call it something called venous insufficiency. It just means that things don't pump up and down as much, and things pool and fluid pools, and you'll get some swelling. It's not dangerous. It may not be as cosmetically pleasing for you, but the treatment for that is to wear those compression hoses that you mentioned, elevate things as much as possible, and you can try and limit your salt intake a bit. Sometimes that helps.
I would add, this person was on blood pressure medicines. There are some medicines that can make your swelling worse. Some of them are blood pressure medicines. So I would mention it to your doctor.
100%.
Sometimes I have this conversation and I'm like, well, how bad, how much is it bothering you? Because your blood pressure is well controlled and, we might have to, but sometimes it's a bother enough that we do make a change if you're on that type of medicine. So, good. We have a caller from Sioux Falls. What are the opinions on the Inspire machine that gets planted under the skin? They called it a CPAP machine. It's a little different, but a treatment for sleep apnea. So, hypoglossal nerve stimulator. I think this season we've done a whole show on sleep apnea, so they probably have a lot of information on that show. You can find it in our archives. But Carolyn, have you had this conversation with patients?
I have a couple of patients who've had it done, and it can be a good option for people who don't do well with a CPAP, but it's a very select patient that it's going to be right for, and so that's a conversation to have with your doctor or your pulmonologist. So the way that it works is by stimulating the nerve that kind of helps to hold the airway open. So it's an interesting way to try and deal with that problem, but it's not going to be right for everybody.
Yeah, there are definitely criteria, but more information on the Prairie Doc archives for sure. Let's see, a caller from Beersford asks if compact stools indicate a need for more fiber or if he should see a doctor. So let's talk about constipation. You probably see extreme cases of constipation in the emergency room. What do you advise people about constipation as far as how to manage that?
Well, there's a really great book for kids that everybody poops, and there's nothing worse than when you can't. Nobody realizes how disturbing that is when that occurs, and you'll maybe talk to parents and grandparents, and they talk about it a lot as a result. So it can be signs of things. And of course, my area is emergency medicine. So the times that it's an emergency, of course, is when there's a change in the caliber or frequency that is something that you have noticed over a shorter period of time. So this isn't something that's happened over the last decade, but more so, hey, over the last few months, either I've had something like they call it pencil caliber stools, or I've noticed that my stools have gotten harder, but it's a new thing and there's no new medications or no new diet changes, and there's blood coming with it as well, and I've noticed these types of things. Those you should talk to your doctor about. There are more things to adjust your stool consistency and your ability to stool than there are shelves on the grocery store, is what I tell people. But the good news about that is that there are a ton of options for you. Don't feel embarrassed about it, because it can really affect your life. And some people have different schedules for that. And there's a lot of different things that are normal. But when it's not normal for you, is when I think you do need to go see your physician about it. Because just talking to some friends and stuff and close people doesn't always help, because what is normal for some people is to have a stool once every 3 weeks, even in some extreme cases. Other people, twice a day, every day. But if there's a change for you, that is a time that can be an early indicator of something else going on, and you may need to have something like a colonoscopy done, or of that, especially if there's some family history.
Yeah.
Do we have an age for this person?
We don't. Okay. Let's assume it's an adult. But
40, starting at age 45, we recommend colon cancer screening. So.
Yep. That would be the first thing that we would look at. Have you had your colon cancer screening, or do we need to talk about that? And then, there's lots of options. Fiber, fiber can help. Sometimes solid fiber might actually make you a little more bulked up. I personally, the first thing I usually recommend is Miralax or polyethylene glycol.
Same.
All the way. Okay. Okay. From Facebook, this person is dealing with a relative who's 73 and has been in pain for 5 months. They have a PCP in their rural clinic who's concerned and has prescribed some medications. They see an oncologist because of a cancer diagnosis. Has been to the ER and sent home, has been to behavioral health and has sent home, and has lost a lot of weight, 45 pounds, and can't eat due to the pain. What to do? So this sounds like a stressful situation. I'm sorry that your relative is going through this. So I'm gathering some medical complexity, pain, which we don't know the details of where that pain is, but that much weight loss I think is worrisome for anybody. Yeah. So I guess how would you advise a patient coming in with some of these symptoms, Carolyn? We don't really know what workup they've already had, but they require some workup for sure.
For sure,
yeah.
And that's going to vary depending on some of the details of the situation and the cancer diagnosis and all of that. But I think the most important part is to first acknowledge that this is really hard.
Yeah.
And it's hard to see a family member who's going through something like this and to feel like there's nothing that you can do.
Yeah.
Which isn't exactly true, right? You can feel very helpless, but advocating for your family member, going to appointments with them, I think it can be helpful to bring that second set of ears. So sometimes we don't want to complain, but this is a situation where I think it would be good, where your care team needs to know how significant the symptoms are and how they're getting in the way of your daily activities and your daily life. And bringing another person with you to your appointments may be helpful to say, well, remember, you couldn't go and do that.
Whatever it is. Yeah, good advice. I think advocating for your family member is really good advice in this person. We had a Facebook question, 21-year-old woman with history of migraines and a recurring headache on the left side of her head. What could this mean and what can I do about it? You see a lot of headaches in the emergency department, don't you, Arleigh? Yeah.
So there are different types of headaches is the first thing we always say. And what the emergency department does are two things with headaches. the very first thing that we have to do is make sure it's not an emergent headache.
Yeah.
And the thing we worry about the most with that is, frankly, bleeding in the brain. This is usually a thunderclap headache that occurs. There are some things we look for very specifically in that case. Now, that is different than the recurrent headache that is having spikes, where I have chronic headaches, which can be very debilitating. This is a bad one.
Yeah.
And you need to come in because your normal regime isn't working. The workup for the brand new, out of nowhere, very different headache will be different than this is my chronic headache, but it's much worse today and I can't cope at home with the medications that I normally have, and we do 2 pathways. With the acute headache, it's a pretty big workup with that brand new different thing. It ends up with CAT scans and blood work and sometimes spinal taps, and it's pretty extensive that we do for that type of headache. It's a long emergency department visit with a lot of interventions being done to make sure it's not that life-threatening thing. If it is typical for your headache that you have, which a lot of migraineurs will have, this is the usual location of my headache, this is the quality of it, this is what it feels like. Some people get stabbing, some people get squeezing, all those different things. You may have your aura or the precursor symptoms before that headache, which are typical for it, but my medicine just isn't working this time because I've been more stressed, or I didn't get sleep, or there was many other triggers that can occur that are out of your control most times, that we can then help with medications that are a migraine cocktail. That what we try and do is break that headache cycle to get you to a point where you're able to go home and sleep, to settle things to that point where it's back down to your basic chronic headache cycle and symptoms that are normal for you. However, I always tell people who are migraineurs, if this is different and not just more painful than your normal migraines, that also is something that needs to be investigated. And there's whole specialties on headaches, so we can't, what could this be? There's whole textbooks on things that could be. But the big thing that we have to figure out is this it's worse pain, but my chronic, then you can get some immediate relief in the emergency department, but then we'll refer you back to your neurologist, because you may need different types of medication to help control and prevent these migraines, as well as different rescue medications at home, versus the type of headache where this is a whole new thing that we got to work up from scratch. But both, we are a place that you may need to come. Both are probably going to need follow-up with your primary or specialist.
It sounds like this is somewhat chronic, and I mean, the great news for this person, start with your primary care provider, but we have like a lot of options for reducing migraines now, even more than 5 years ago. If you're suffering with a lot of headaches, get seen about it. Good. Culture plays an important role in healthcare, influencing how providers approach and deliver care. Dr. Jennifer Tingley is Chief Medical Officer at Falls Community Health in Sioux Falls and a faculty member at the University of South Dakota Sanford School of Medicine. She oversees the university's Cultural Immersion course. Prairie Doc spoke with Dr. Tingley about this medical school course and its significance in preparing future healthcare professionals.
The Cultural Immersion course is for second-year students to participate in.
It is an opportunity for the students to kind of gain some understanding of just different cultures that they may interact with in their practice. And it doesn't matter what type of doctor they're going to become.
The course covers different countries, backgrounds, and religious beliefs.
We have Keith Hansen, who's a wonderful physician. He's a reproductive endocrinologist, come in and talk about some of the genetic conditions that they may be exposed to, where there's unclear anatomy or perhaps both sets of anatomy. And so we learn about things like that. So that's one day. Another day within Cultural Immersion, that course is to take all of our Pillar 2 students and we go to one of our Hutterite colonies here in South Dakota. And we spend about 3/4 of a full workday touring. And so we get to see their school, we get to see their homes, we get to see their work.
Tingley says this course is important as it teaches how to ask questions and understand various cultural practices and views.
We need to make sure that our young and budding physicians are as equipped as possible. And again, it'd be different if we lived in New York City and you're just surrounded by tons of people that are coming from all over the world, and there's just a myriad of languages being spoken all the time. But in South Dakota, that's just not the case. And so I think it's important to be more intentional with it, and make sure that students understand and feel a little bit more comfortable. It's just a week, it's not the same, but it's the start.
Thanks, Dr. Tingley, for helping us with that segment. We'll get back to some questions because we've got a bunch. We'll try to get as many answered as we can here in the last minutes that we have. An email question, this person must have recently been in the ER. Yes, they had a CT scan, an MRI, an EKG 4 days ago because they had something that they describe as a gray veil over their left eye. Yep. They did not find any evidence of stroke at the time, but found something that resulted in a referral to a neurologist, but they're waiting for the neurology referral. What might it be? How worried should they be?
Well, the good news is you don't have to be super worried right now, because you had a very extensive workup that was looking for stroke, most likely, when you have that veil come down over your eye. What we worry about, there's a fancy name for it even, called amaurosis fugax, and doctors love to make these funny names for things that make no sense. When a veil drops, we want to know about that. You probably had an exam of your eye to make sure that it wasn't something to do with the eye itself, like a detachment of your retina or at the back of the eye. Now, there are a number of times that things can be warning signs, though. So we'll sometimes have you follow up to have further evaluation done. But it can be a number of things. A migraine can present this way as well. It could be something called a TIA, or a transient ischemic attack, and that can be a precursor. That means you may need a little bit more workup for strokes. Even seizure activity can present like this. So we usually start with a neurologist if we don't find anything structurally wrong in the brain, in the blood vessels that feel the brain, or in the structure of the eye that we can see, and that's why we do a number of those tests. Then we refer you on to the first specialist to see if this can be addressed. Is this a headache, which strangely enough, this type of migraine, you may not even get a headache with it. You just get this symptom on the eye or the vision. You also could have something else going on with, like we say, talk about these atypical seizure or partial seizure disorders that can present with this. So the next step is with a neurologist who will review everything that was done, get more history from you. The big thing you need to do at this point is, if anything gets acutely worse, meaning there's a sudden change, come back to the ER. That's okay to do. The second thing to do is keep a diary of your symptoms, of what's been going on since that time, because your specialist will want to know that. And it's hard to remember. And those times when you're thinking, should I be worried about this or not? Write it down. It's a wonderful thing to write that down, because that's all information for you to bring for that appointment.
Good. Let's see, Carolyn, a question for you. What are some issues caused by the long-term use of ibuprofen and or meloxicam? So I guess NSAIDs in general, ibuprofen is probably the most common one that people know about. But what do we worry about?
So these medications, we use them a lot. They're really helpful for a lot of things. But with chronic over years use, that you can develop some issues. We worry about the lining of your stomach, that you could develop thinning of the lining of your stomach that can lead to ulcers. We can also see issues with kidneys and kidney function over time. So for people who have a little bit of issues with their kidney in the first place, we try to limit these medications. But there can still sometimes be a way to use them carefully and responsibly, even for people who do have some early kidney issues.
Okay, Good. Email question. We recently had a bat in our house. It's probably, right, that time of year. Our doctor recommended we get a rabies vaccine. Why was it so important, and why was it so many? Arleigh, you probably get the rabies exposures in the emergency room too, right?
So often and so common. My cat loves it if a bat gets in my house and chases it all around. And I live in an area where sometimes one of my pets may or may not bring me a present and present it on the front step, and it may or may not be a bat on occasion, which makes me quite stressed out. So the reason why we care about this, and that we love our pets and we love our homes and we love this area, and bats are great because they eat the mosquitoes, and that's a wonderful thing too, is that bats can carry rabies. If you do have a bat that is in your house, one of the things to do is don't throw it out once you've killed it, if you do, or you find it dead, because you can have it picked up and they will analyze if the bat has rabies or not. And that's the first thing to know about, because that may change if you have to get a rabies vaccine or shots or anything. Now, the problem is you sometimes don't know, which this sounds, I know, incredibly strange, and it did to me as well, if the bat bit you. I feel like I would know if a bat bit me, but apparently you don't always. They're sneaky. So if a bat bites you, you may not even know that you were exposed to it. So current recommendations are, if a bat is found in your house, then you should get the rabies vaccine. If they do find a bite on you, then you also have to get immunoglobulin. The reason why it's so many shots is because rabies is incredibly hard to treat. We don't want anybody to get it. You do have a window of time before you have to get those shots. That's the other thing I tell people. So, if these exposures happen with a cat that scratches you, a dog that bites you, or a bat kind of idea, if things can be quarantined, you sometimes can get out of it. But currently, the only way to treat this is with, a lot of shots over a number of days, and there is a schedule to follow for it, and it is important for you to get all of them.
Yeah, good. Facebook question, this person is on Eliquis or apixaban after an ultrasound diagnosis of a blood clot behind the knee. Are there any dietary or exercise or other restrictions that this person should observe on the Eliquis? Anybody?
So maybe in the first few days to weeks after a clot is recognized, we wouldn't want you doing any kind of vigorous activity, because we don't want that clot to break loose and travel somewhere else. But more generally speaking, on Eliquis or any other blood thinner, you're going to be more apt to bruise. So you can try and be a little bit more careful, but it's probably going to happen anyway. I don't know that there's any major activity restrictions that we would need to observe.
Sure.
No, and same with the dietary. That's the advantage we used to. So DOACs, as they're called, and Eliquis is one of them, is a newer generation of blood thinners, and the advantage of them is that there's less variability with your diet. The other one had to, you may have heard about this, and maybe this is why you're asking, if you were previously on a medication called Coumadin, you had to be quite aware of what you ate and the similarity of what you ate, because it would adjust how therapeutic or how thin your blood was, and that is one of the advantages of the newer medications, so that we don't have to be as rigid with those types of things. And don't fall down. It's the big thing.
Do your best.
If you fall down and hit your head, then you got to come see me, and then we got to do a head CT to make sure there's no bleeding. So.
We've got 5 minutes or a little less, so we'll just try to rapid fire through some of these remaining questions as best we can. Since entering my 40s, I've had breast pain all month. Mammograms look fine. What could be causing this, Carolyn? Glad the mammograms are fine. You've done the right thing if you've had it looked at.
That's the first thing to do with looking at this. Generally, breast cancer is not painful, but it's always an important thing to rule out. So good thing that the mammograms have been done. Things that can cause breast sensitivity, caffeine intake is one. Changes in the breast just with aging and making sure that your bra is well fitted and well supporting. Those things can help. There's been some kind of conflicting evidence about evening primrose oil supplements, but I think it's something that's kind of worth a try.
Safe enough,
So that may help.
It also could be perimenopausal, and people don't appreciate that how early we're finding some of these symptoms. So I would speak to your doctor about it, because this might be the example where you can have the discussion about, am I entering into my perimenopausal time frame? Because we used to think, oh, it was just in 5 years. Now that keeps extending.
More like 7 to 10.
Yeah, so you may be able to get some relief depending on how disruptive it is.
Good. Okay, Arleigh, answer this quickly. What can cause ongoing chest pain that comes and goes when it's not a heart issue? So it sounds like, let's assume this person had chest pain, has had their heart well checked out, which is great, but they're still having chest pain.
So there's a lot of things, unfortunately, that can cause it. So in your chest cavity, many things that exist. Could it be your esophagus? Yes. Could you have bad heartburn? Yes. Could it be reflux? Yes. Could it be pleurisy, inflammation of the lung lining? Yes. Could it be your muscles that are sore because you're getting older? New activity? Yes. All of those things at the very least are possible as reasons for chest pain. The thing we worry about, of course, is the heart, because that can kill you the quickest, and that's why we have to rule that out first.
Okay. Good. Let's see. We've got a few questions that we can try to answer. We had a question on UTIs and estrogen, which we actually addressed at the beginning of the show, so I'm going to skip that part. But question, if we've ever heard of hearing loss as a result of COVID-19. Carolyn, have you seen any cases of that?
Not that I can think of.
Yeah, I'm not aware. I mean, I would never say it's impossible to have a viral insult that led to something like that, but I think not
we
common.
see some strange things after COVID.
And so long COVID is being reshaped and reclassified every week, it seems like. So it is not outside of the scope of possibility, as well as depending what medications you may have had, depending how bad your COVID was, and when you were in the hospital for it, and what was done, and what other illnesses you had associated or as a result of your COVID infection.
All right, we got 1 minute. We had a caller from Custer ask, what causes old lady or old man voice, and is it inherited? Let's assume, I'm not sure if this is true, but it's a voice change. I guess, how would you approach that in your patient, Carolyn?
Sometimes it can run in families when you see something like an essential tremor, and a tremor that can affect the vocal cords, where you get that kind of tremulous quality to the voice. That could be a possibility.
So things you have to think about. If it happens acutely, so it happens suddenly, you need to be checked out for a stroke. That's just one of those things. If it's happening gradually and there's not a familial component, you also need to be checked out, because there are some things where there can be compression with tumors that can cause issues with this. Other thing that's pretty common that you need to be looked at is to make sure your thyroid is okay, because that's near your voice box, and that's where you can have some issues with that. So that should also be checked as well. And there's actually a number of neuromuscular disorders that sometimes present as you get older, that this could be a first precursor of, and there are a number of tests then that would need to be done if that's occurring.
Great.
Things like myasthenia gravis comes to mind.
Our winner tonight is John. A book will be sent to you shortly.
Congrats, John.
We'll be back after this.
Overwhelmed with the amount of information available? Not sure which sites to trust? Head to the Prairie Doc YouTube channel today to access all previous On Call with the Prairie Doc episodes. And make sure to join us most Thursdays on SDPB or streaming on our Prairie Doc Facebook page.
You're never fine.
Thank you to our guests, Dr. Gilbertson and Dr. Trainor, for volunteering their time to help us answer all of your medical questions. If you would like to see and hear more episodes of this program, please like and follow us on Facebook, Instagram, Threads, YouTube, and TikTok, or visit us at prairiedoc.org. Look for Prairie Doc Perspectives in your local newspaper and online. Listen to us on Prairie Doc Radio on SDPB Sundays at 6 a.m. and 1 p.m. And be sure to look for the podcast of this program, Prairie Doc On Call, wherever podcasts can be found. From all of us here at On Call with the Prairie Doc, thanks for joining us for another episode of health information based on science, built on trust. Until next time, stay healthy out there, people.
Dementia is not a single disease. It's an overall term to describe a collection of symptoms that one may experience if they are living with a variety of diseases, including Alzheimer's. Understanding memory loss and dementia, next time on Call with the Prairie Doc.
My name is Dr. Tom Dean, and I serve on the Healing Words Foundation Board, the nonprofit organization that runs Prairie Doc programming. Our mission is to enhance health and diminish suffering by communicating useful, science-based information respectfully and compassionately. Your donation supporting Prairie Doc programming makes an extraordinary difference. Gifts of any size enhance its impact in our state and beyond. Thank you for your generosity.
Major funding for On Call with the Prairie Doc has been provided by
At Avera, our nationally recognized health system will be right here with you, with care and coverage. Hello possibility. Hello healthy. Hello life. Avera, moving health forward.
Larson Manufacturing is proud to support On Call with the Prairie Doc as it continues to open doors for important medical information. And with the ongoing support of these individuals and institutions, Brookings Health System, South Dakota Academy of Family Physicians, Sanford Health, Avera Medical Group Brookings, Avera Heart Hospital, First Bank and Trust, Dakota Allergy and Asthma, Monument Health,